Hi, my name is Laura Bailey, and this is my case presentation for Medical Biochemistry 1 on September 21st, 2019. So I decided to start with case presentation number 3. So here we have a 5-year-old boy who presents with his mom for an annual visit. His mom states that he appears drowsy, has persistent thirst, and frequent urination. They did some blood work, and according to his serum insulin levels, it looks like the patient has a significantly lower insulin level than the control at baseline and 1 hour after the glucose load. So what do these results suggest for him? He has a possible undiagnosed type 1 diabetes mellitus. We see that the insulin level is significantly less than the control at baseline and after the glucose load. So this could mean that there's potential issue with the production of insulin because we're having an inappropriate response to the glucose load. In Chapter 14 of the book, we learn that the function of the beta islet cells of the pancreas is to produce insulin in response to elevated blood glucose levels. So we may be seeing an issue with his production of insulin here. So what might this suggest about the patient's fasted blood glucose levels is that they're likely above normal range. Since we learned that the function of insulin is to lower blood glucose, if a patient isn't producing enough insulin, then the blood glucose levels are likely to not be lowered and are likely to remain elevated. So what happens to all that glucose circulating around in the blood? Well, normally glucose is brought up into the cells by GLUT2 and GLUT4 transporters for the process of glycolysis. If there's insufficient insulin produced, the glucose remains in the bloodstream and the glucose levels will remain elevated. Because the glucose is not taken up into the cells via glucose is not taken up to the cells and glycolysis does not occur, the body will begin to think it's starving or begin to start its fasted state metabolic pathway. So it will begin breaking down glycogen stores and even muscle mass. So we'll see the processes of glycogenolysis, gluconeogenesis, and lipolysis take place. Because glucose will be released into the bloodstream through these fasted state metabolisms, the blood glucose levels will likely elevate even further. So it's likely that this patient will have gluconeogenesis occurring, and because that, we'll see some elevation in some of the regulatory enzymes in the body. So we learned in Chapter 19 of the book that gluconeogenesis is essentially the reverse pathway of glycolysis. However, there are some irreversible pathways of glycolysis that we need to overcome in gluconeogenesis. So here we have our regulatory enzymes of glycolysis, but in gluconeogenesis, in order to overcome those irreversible pathways, we'll use the enzymes pyruvate carboxylase, phosphoenolpyruvate carboxykinase, fructose 1,6-bisphosphatase, and glucose-6-phosphatase. So in this patient, we're likely to see the symptomology of this patient includes frequent urination, drowsiness, and persistent thirst. In an article I read called The Biochemico-Physiological Mechanisms Underlying Signs and Symptoms of Diabetes Mellitus, written by M.B. Adinurti, he explains the symptomology here. So we have frequent urination, which is also known as polyuria or nocturia, which is termed because the patient can be up urinating frequently throughout the night. So this is likely a result of prolonged hyperglycemia. So this frequent urination throughout the night can also contribute to drowsiness. Along with that, the patient may be in a catabolic state as they're breaking down amino acids and free fatty acids for fuel, so they're likely to feel tired because their pathway for glucose metabolism is unavailable for typical ATP or energy production. Lastly, the patient does have persistent thirst, which is also known as polydipsia, and this generally occurs because the patient's urinating so frequently that they're likely becoming dehydrated from an overall volume loss in their body and therefore are trying to drink a lot to overcome that. So these are the symptoms that the patient is dealing with, and it's likely undiagnosed type 1 diabetes mellitus. So next we move on to case presentation 4, where we have a previously healthy 2-month-old female. She's been fed breast milk only since birth. Recently, they increased the time between feedings, and her mom notes that the symptoms seem to begin after the increase in time during feedings. So, signs and symptoms that the baby presents with are jittery spells several hours after feeds, not during feeds, hepatomegaly, and hypoglycemia during fasting. They do some labs, and those labs are consistent with hypoglycemia. They give epinephrine in order to raise blood glucose levels, and the blood glucose levels do not increase, but there is an increase in blood lactate. So, in an article that I read from the NCBI, epinephrine administration under normal conditions increases blood glucose by stimulating hepatic pathways of gluconeogenesis and glycogenolysis. However, our patient presents with hypoglycemia despite giving epi, and since these two pathways occur in the liver, it's likely that our patient is having a malfunction in their liver. So what's up with this fasting hypoglycemia? Because our baby is able to maintain blood glucose level after feeding but unable to maintain during the fasted state, this further suggests a malfunction of the patient's liver, specifically the pathways occurring in the liver, glycogenolysis and gluconeogenesis. Since we don't see an issue with glycolysis, since the baby is maintaining their blood glucose while they're feeding, we're seeing an issue with the utilization of the stored glucose or the glycogen. This may explain why the patient was asymptomatic until the feedings increased, because they were likely getting a fairly constant influx of carbohydrates and were never really reaching that fasted state while they were feeding this frequently. So since there's a disruption in this pathway of glycogenolysis during the fasted state, I think it's reasonable to assume that the baby is struggling with glycogen storage disease. So what is glycogen storage disease? It is where we have a deficiency in the enzyme of glucose-6-phosphatase. Glucose-6-phosphatase is unable to be hydrolyzed in this process so that glucose can be exported into the blood. So we can see here that we have our glycogen and we dephosphorylate it to glucose-6-phosphate. And then here where we have our deficiency in our enzyme glucose-6-phosphatase, this is our problem area here, so we're not able to get the glucose out into the blood, and therefore we have hypoglycemia during those fasted states. We might see an increase in the blood lactate because the glucose-6-phosphate, since it's not going to be used in this pathway, it's going to be used in other pathways, and here it's going to overwhelm the Krebs cycle, and there will be an overproduction of lactic acid, which is where we're going to get our lactic acidosis, which is what our patient also has. So additional symptoms, hepatomegaly is likely a symptom of this because of the baby's inability to perform glycogenolysis. There's a buildup of glycogen stores in the liver, which leads to hepatomegaly. And then our jittery spells are likely related to persistent and frequent episodes of hypoglycemia. So why isn't it glucose-6-phosphate dehydrogenase deficiency? Well, this enzyme is essential in the pentose phosphate pathway, and the goal of the pentose phosphate pathway is to form ribose biphosphate essential for nucleic acid formation. So deficiency in this enzyme is likely to lead to symptoms that our baby is struggling with, or specifically hypoglycemia, and this enzyme deficiency actually leads to anemia according to the Genetics Home reference. So what about hereditary fructose intolerance? Well, according to the Genetics Home reference and Chapter 20, we learned that hereditary fructose intolerance is an inability to digest the simple sugar fructose. So this is a deficiency in the enzyme aldolase B. And when this happens, we have an accumulation of fructose-1-phosphate in the liver, which sometimes leads to hepatomegaly and fasting hypoglycemia, which we may see when the baby is not feeding as often. Now this sounds right, but I can immediately rule this option out because the baby has been fed only breast milk since birth. We learned in a video about fructose metabolism that breast milk contains lactose, which is made up of galactose and glucose and not fructose. So this is not an option at all. Furthermore, since the baby is able to maintain blood glucose while feeding, there's likely no issue with the digestion of the sugar, just the utilizing the stored form of it. Because there's a difficulty maintaining blood glucose in the fasting state, there's likely a malfunction in the metabolic processes to deal with maintaining an appropriate blood glucose in the fasted state, which why it still leads me to believe that it's an issue with the metabolic process and why I still believe it's glycogen storage disease. Lastly, are we sure it's not galactosemia? So what do we know about galactosemia? According to, again, the genetics home reference in chapter 20, we learned that galactosemia is a problem breaking down the sugar galactose for energy. So when there's a problem breaking this down, we have an elevation of galactose 1-phosphate in the liver. So the symptoms that this baby may have are the infant may struggle to gain weight. There may be a failure to thrive. However, there is no direct cause of a fasting hypoglycemia, which is something that the baby struggled with. And because the breast milk contains galactose, the baby would likely struggle with hypoglycemia even while feeding. So because of the GALT deficiency, the liver will likely accumulate high levels of galactose 1-phosphate, which will be toxic to the liver amongst other systems in the body, and this would likely lead to hepatomegaly, which is a symptom that the baby is having, and even though it's an identical symptom, this does not explain the jittery spells. Lastly, a common symptom of galactosemia is cataracts, and this is from the buildup of galactocol, or the reduced sugar form of galactose 1-phosphate. And this is produced when there are toxic levels of galactose 1-phosphate. So a buildup of this and this reduced sugar form can lead to cataracts, and we don't see this symptom listed. So it's likely to assume that galactosemia is not the answer. So again, I choose glycogen storage disease as this baby's potential disorder.